Thank you all for coming. I know that 4 o'clock on a Thursday is a tough time slot, so I appreciate you all sticking it out. I'm Raquel Derrick. I'm from the Diversion Center in the Division of Forensic Services at the Office of Mental Health. I'm joined by my colleague Alex Van Lupin today, and then our director Trisha George is cheering us on from the stands. We're going to take a few minutes to kind of set the stage for this presentation about establishing partnerships between law enforcement and behavioral health populations, and then we're going to turn it over to some of our partners that are going to tell you about the really interesting work that they're doing. So we just wanted to open it up and give some of the information of, why the Diversion Center really exists. Alex is going to talk more about us specifically, but we've been in existence since 2020, and we really came out of the recognition that we have a challenge of incarcerating people with serious mental illness in this country, and that they are overrepresented in incarcerated populations and in law enforcement interactions, and all sorts of experiences. Many of those who are incarcerated with serious mental illness, about 3/4 of them, also have a substance use disorder, so co-occurring. These can be intensive needs, and just a recognition of, we really need to be looking at if there's more appropriate alternatives to dealing with these individuals than what we currently are doing. I will say that these are national statistics. New York State tends to do a little bit better on everything. This is something that we've been aware of for a while. This is something that commissioners at many of our state agencies, certainly mine, Office of Mental Health, I think DCJS, who is sponsoring this event, are really aware of and committed to addressing.
All right, so now, again, Alex Van Lupin, I want to talk about the Diversion Center itself and the whole of who we are. So what the Diversion Center supports, and I'll read this up here because it's very important, is the jurisdictions in the development and implementation, evaluation, and application of initiatives to reduce arrests and incarceration of persons with serious mental illnesses. SMI. That's what the Diversion Center stands for. That's what is our kind of like I guess you're saying mission statement. What we try to do the most of, and we also focus mainly on adults, but we focus the entirety of what we call diversion. So our main goals are supporting local criminal justice jurisdictions to develop and implement their own jail diversion, assessing local resources, practices, and service gaps through sequential intercept mapping. I won't go too much into detail what SIM is, but if you are curious about what sequential intercept mapping is, come find me at the presentation and I can tell you all about it. Develop and support collaborations between the criminal justice, mental health, and substance abuse systems. So when we talk about our initiatives that we are supporting, we have actually a few pilot programs that we've actually piloted ourselves through the Diversion Center that we are focusing on. There are about 7 pilot programs in 2022. They all focus on these different intercepts between 0 and 3. Again, it's more about the sequential intercept mapping, but I can tell you more about, it's more like a pre-arrest model in a sense, or initial arraignment. So when I talk about these intercepts, we're talking about now what we call diversion, crisis centers, and crisis respite, post-arraignment diversion, and enhanced release under supervision, which is a little bit getting closer to more of enhanced release in the sense of like probation post-arrest, but it does have a little bit of intro on that pre-arrest. Specialty courts, jail clinical staff, peer supports, and forensic care management. These are just a few of the things that we are going to be focusing because more in relation to what we're talking about today, but the Diversion Center also focuses on all the entirety of criminal justice intercepts, including post-arrest and reintegration. So when it comes to technical assistance, is one of our bigger parts that we work on. We try to develop that first part there, a catalog. We want to really create a library of resources that we have to be able to have on hand so that when we talk about with partners and communities and counties that are looking to actually start their own diversion, it's more of like we want to be able to have a kind of resource element for them to actually build something off of, or even add something they already have already. Which kind of goes into training and resources. We always know that training is very helpful when it comes down to to do actually low cost, because then we actually are working on the current system as it is. So we actually have our own sequential intercept map facilitations that we do, and we also do a lot of the WebEx training series that we have as well as some research initiatives that we've also started actually this year along too. So when it comes to data collection, it's one of our bigger parts with our pilot programs. We have to collect quarterly data with all of them so that we can actually take those initiatives and actually build upon the research initiatives that we already started now and help us build more to what is there about data about diversion, since there's not a lot of information that's out there. So that is just a brief overview of the Diversion Center. I really want to give time for our partners today, but I really want to take a moment for anyone that wants to take a picture here, because this is our contact information. I really want to stress if you have any questions at all, what you see here today, or anything about the Diversion Center, please email or even go for the general assistance that I learned. It's right there. Again, that's for me, Alex, Philippin, and Raquel, and our director, Tricia George.
And when I introduced myself, I should have said that I'm the researcher for the center, and so now we're going to bring it back to research for a quick minute and just set the stage around police and behavioral health partnerships and why we're focusing on this. And so we know, and probably everybody in this room knows, that law enforcement has in many cases become de facto first responders to crisis situations in the community. We know that there's a high volume of interactions with people who are experiencing crisis. We also know that this can create some challenges for individual officers and departments, in terms of resources and training and responding to these individuals. And we know that unfortunately, people who are in behavioral health crisis are at greater risk for an adverse outcome of their interaction with law enforcement. And so that's why we know that it's so important to really bring behavioral health into the fold when it comes to law enforcement responding to people experiencing crisis. There's a lot of growing support for it. Some examples that maybe you've heard of or seen of law enforcement and behavioral health partnerships include embedded social workers in police departments, mobile crisis stabilization centers, which is a good segue to our first partner. So we have invited two of our partners that we work with in the Diversion Center, who we think are just doing a really stellar job on this front of partnering between behavioral health and law enforcement. The first program I'm going to introduce is the Diagnostic Assessment Stabilization Hub, or DASH, out of Suffolk County. And we're just going to bring up their PowerPoint and let them tell you more about their program.
Good afternoon, everybody. So it's wonderful to be here. One of the things that I wanted to start off with is by saying that when you think you know someone so well, you take a 3.5-hour drive to Albany, and what you find out in that car ride. I'm even more impressed with Officer Bridget Topping, my partner here. But anyway, it's great to be here. It's a passion of mine in terms of the intersection between law enforcement and behavioral health. And behavioral health, when we talk about behavioral health, it's just the umbrella term for mental health and substance use. So, as Raquel mentioned, DASH is really a hub, and there's a continuum of crisis services. So, for years, we knew there was a huge gap in the larger system. It was either bring someone to the hospital or try to connect them to outpatient care. So we worked with our local government unit for years, and knowing that this was something that we were just so passionate about and really mission-driven, saying that we have to do a better job. And 5 years ago, we created DASH, and connected to that are mobile crisis teams, as well as 24/7 hotline, crisis hotline, which is now connected to 988, which is the National Suicide Prevention Lifeline. The Crisis Stabilization Unit is 24/7 as well. So just to give you an idea, it was really meant, it was basically studs when we started. So we had the ability to work with and really research crisis stabilization centers around the country and figure out what's the best throughput, how do we really develop this, how do we create a stabilization center that makes the most sense. So we wanted something that was welcoming, that was recovery oriented, that was non-hospital-like, And just to give you an example, when you first walk in, here's the reception area, you have a waiting area, you have a large family room and a small family room. You know, we have computers that are on carts. The space can be used so flexibly because it depends on who comes in. It's like an emergency department in that way. You could have 5 people walking through the door, you could have families and siblings, and we can flex our space depending on the needs at any particular moment, based on the space that we have. Here's the nursing observation area. We have recliners that are, you know, really line around the observation room. And then we have the police entrance. So we have a separate law enforcement entrance for drop-offs. And we have a triage room where when people do get dropped off, law enforcement will provide some basic information and will let us do our triage to make sure the person is appropriate. So we are very proud, and I think based on national statistics, the people that come to DASH are appropriate. It is, I think, really due to the wonderful partnership we have had about a year or two prior to the opening of DASH with Suffolk County Police Department, they were at the table in terms of planning for this new level of care. So we spent the time, we did the due diligence, we really went and spoke to all officers in all of the 7 precincts and all shifts to really explain this new level of care that was coming down the pike, what it was, what it wasn't, how does it compare to a hospital, when is it appropriate to bring someone to a crisis stabilization center. Because the last thing we wanted were for the officers to bring someone that was inappropriate, which again is the exception. There are many cases where it's quite appropriate, even if they're suicidal, even if they have thoughts of harming themselves, I mean, they can still come. It's really only if they're imminently at risk should they go to the hospital. But the work that we did and opened the dialogues and had conversations and went over real life cases and examples allowed us to really make sure that we were steering the right people. And we also created a law enforcement telephone line that the law enforcement officers could call if there were questions about disposition. So it's a long way of me saying that of all the people that come to DASH, consistently since we opened 5 years ago, only 1 to 2% need to be referred to the hospital once they get there. So that's a very low number, and we're proud of that because the last thing, like I said, we want is for them to drop someone off, law enforcement, and then have to then bring them to the hospital. So in addition to Suffolk County Police Department, which is the 12th largest police department in the country, with close to 2,500 officers, we work with the town and village police departments on the east end of Long Island, as well as the university police, such as with Stony Brook University, which is close to the center. Another proud statistic is that, again, very consistent, is our triage and our ability in terms of that transfer of care to us has averaged about 22 minutes. So when you think about when you have to take 2 law enforcement officers out of their sector, bring them to a hospital, and wait for that transfer of custody, that could be hours. And in our county, it was hours. And it really was a strain on resources in the past. The other thing is that when officers would take them, this was a pain point. This was one of the reasons why we knew we needed we needed to re-engineer the system, is that all the officers that would take clients to the hospital in Stony Brook, which is the comprehensive psychiatric emergency program, about 25% were admitted. So the vast majority were not admitted, and they would just be turned right back around. Not with an aftercare plan in place, and really kind of had that revolving door. think Raquel mentioned, or there was some mention about mobile crisis, so it's, again, I think we're blessed with a continuum of crisis services that work hand in hand. So not only do we have the stabilization center, but we have mobile crisis teams, as well as the hotline, and all the staff are cross-trained and they all work together. We have one software application that ties all the components together. So there's different reasons why we may have a co-response. It can be initiated by SCBD. It could be initiated by our mobile crisis team staff if there's a history of violence, if there's a concern about safety. We may determine, the mobile crisis personnel may determine that this person does need to be transported to the hospital, and they have a specific form they can use similar to what they call a 945, which is a 958 that's specific to the mobile crisis team. And they could, basically, or, tell the police that this person does need to go to the hospital for further evaluation. So our collaboration has been, it's just been something that has evolved over the years. I will say that a catalyst was police reform in terms of being able to scale our efforts, being able to start with pilots, being able to figure out what works, what doesn't work, being able to really work the change management process. Because look, this was huge change. We did things that, were, culturally not necessarily comfortable. We were asking to do things that people weren't used to, and we needed to prove our value. So I'm going to talk a little bit about some of our pilots and what we've done, and also share some numbers. But I think we really have innovated. We've created more efficiencies. We've been able to re-engineer that system and really provide the right care at the right time, in the right setting, and really work with our partners in law enforcement to help them so they don't continue to fall into that role of being de facto social workers or de facto substance abuse counselors, or being, uncomfortable in making a decision whether someone has to go to the hospital or are they at imminent risk. So the first thing were telehealth engagements in terms of when officers respond in the community and they're responding to someone with a behavioral health issue. Vast majority are not black and white, where it's completely clear that this person has to go to the hospital. Vast majority, there's a question, and oftentimes people have said, look, reflexively in the past, I'm going to take them to the hospital. I'm not going to take a chance. If someone even mentions the word suicide, they're going to the hospital. All right. So what we really developed is a true operational process that has moved and really move that proverbial needle in terms of having officers in the field being able to call the dedicated law enforcement line. Our crisis hotline is staffed by all licensed professional staff. They will take some basic information from the officer, what precinct they're from, the complaint number, why they're calling, what's going on with the individual. And then our staff will, from our electronic medical record, initiate a link, preferably to the individual, their phone. If not, we'll do something else. But the reason why we wanted to go to the individual's phone is that if we don't need the officer to stick around, we want to be able to dispatch them back, and we can continue to figure out what the disposition needs to be. So we send a link, and then we initiate a telehealth engagement, just as if they were at the Crisis Stabilization Center. We are going to evaluate and come up with the right disposition for that individual. Since we started, 84% of these calls that result in a telehealth engagement, which breaks down all those geographic barriers. Because if you think of Suffolk County is the 4th largest county in New York State. 1.5 million people, 86 miles long. I mean, it's vast, and we cover the whole county. So this allows us to be able to respond in the moment, provide that assessment, provide that triage, and 84% of the people do not need to go to the hospital. All right, so that is a game changer. So I mentioned before, we started with a pilot. We purposely did that. We had to get buy-in. We had to kind of really work that change management process. There was resistance. We had to really persevere and continue and show that, no, we could do things differently. Once they saw the results, because in the past they said, no, we need to bring someone to the hospital. We need to go to a brick and mortar hospital setting. What do you mean telehealth? Before you know it, they were banging the doors down. All the departments wanted to, they said, no, we want to be part of this, because they said, look, we're not tying up the officers, we're not spending hours transporting, and we're able to come up with an effective disposition. And importantly, after each telehealth assessment, we will send a dispositional email of the results. So we send it to the duty officer or whoever they want, whatever the staff department wants the email going to. And from a liability standpoint, we're saying, no, we made, as mental health professionals, we made this determination, we made this assessment, and we're going to let you know the outcome of that. I think we've all heard about 911 diversion, so we have a crisis hotline. So we created another operational workflow where the 911 operators will assess the situation. If there's a behavioral health condition involved, they will ask very specific structured questions. If they don't meet exclusionary criteria, they will offer DASH as an alternative. If the person agrees, they will be connected to one of our licensed professionals. The 911 operator will drop off, and then the assessment and triage takes place. And there can be many different options. There can be many different dispositions. So the licensed professional can continue to de-escalate the crisis on the phone. They can dispatch mobile crisis in the moment or later for a welfare check. They can arrange for transportation to the DASH center. We use a ride share or ride transportation coordination platform, a software called Ride Health, and we can literally request a ride one way or two ways and get that person safely to the center. We can connect them to aftercare, or we can connect them to care if that's what they need. Again, only about 1% of the calls end up needing to go back to 911. All right. What we are very excited about is that in the near future, we are going to have the next iteration, which is to place social workers into the 911 call center, so they can be in vivo, collaborate, discuss outcomes, be able to handle the calls, do cross-training, and be able to work together in the same setting. And it really is the best practice. They do this in other places around the country, such as Austin and different places, and it works extremely well. So we're really excited about the next phase and the next evolution of the 911 diversion. So we have about 12 per month. We think there's low-hanging fruit because we know there's a lot more that could benefit from that. And the same dispositional email gets sent in terms of what that outcome was of the 911 diversion call. The other thing we have done is piloted, a program as it relates to special referrals. So we meet regularly with our behavioral health section, and Bridget Topping here, who's going to share some information, was a co-founder of the behavioral health section. And it is really just, again, allowed for a lot of this work to be successful, just based on the passion that she and the team bring, and really being on the same page in terms of what we want to accomplish. But we meet regularly. We try to be as tech-enabled as possible. We do use a smart sheet to be able to share information back and forth in a bi-directional way. Since January of this year, our focus has been on juveniles that are not connected to care, that are transported to the hospital for the first time. We also work with those individuals that interface disproportionately with law enforcement. They have a behavioral health condition, they continue to interface with law enforcement, and we try to figure out, why is that happening? Are they not connected to care? Are they connected to the wrong level of care? Do we need to, we try to engage collaterals, try to get more information. What can we do to change the outcome? So it's like a case conference, do a deep dive, pull necessary people in, and try to change that trajectory going forward. We have the ability with our continuum to be able to dispatch mobile crisis to try to engage these individuals and figure out what's the best plan going forward. What can we do to change that, to change that outcome? And it's a process, and we stay with them, we outreach, we engage, and we continue to follow them until we can try to change that outcome. Again, I think like anything else, it's all about relationships. We're so fortunate that SCBD is our partner. And I think like anything else, the relationship matures and relationships get stronger. And I think one example is that when there are certain situations, they will now call upon us to assist where appropriate in various situations. So it really has, the use cases have grown. So now, if there's a barricade situation, a hostage situation, oftentimes we also will be involved as an ancillary support, whether it's, trying to figure out what's going on with this individual, what their history is, talking to collaterals, trying to figure out how we can support the situation so it's a safe outcome. So CIT training for all of the SCPD classes. Staff from the DASH program push in and they present on DASH and what it's about, as well as other things such as the 958, the 945, and other educational topics that relate to the training. All of SCPD officers are EMTs. So all of the new recruits, as part of that process of becoming an EMT, need clinical placements. DASH is one of their clinical placements. This has been invaluable because from the beginning of their career, they're exposed to DASH, they understand what DASH is, they have built relationships that they take forward when they go into their sectors, when they become officers. And it's, just like, we have done a lot of training with officers before DASH opened up. This allows us to be able to interface with new officers so that they really understand the crisis services in the county. And there have been hundreds of officers that have rotated through and will continue to do so. So just, again, give you an idea about the numbers, right? So the stabilization center is based on 2023 data. We have close to 400 people a month that come to DASH, either walk in at any time, 24/7, referred from schools, brought in by police, referred from other providers, from housing agencies, etc. 60 to 70% are adults, 30 to 40% are children. We have about 19 to 20, we have about 19 right now, drop-offs per month, but that number was much higher in the past. Once we implemented telehealth, the number of drop-offs decreased because more people are using the telehealth process. And we average, it's really up at this point, 1,700 active crisis calls through our hotline a month. And that's when someone Basically, when they call the hotline, if they push 1, this is an active crisis, that's the number per month, 1,700. So the volume is great, but again, that's often the entree or the gateway into the crisis services, and the hotline workers will determine what is the best disposition. Do we need to bring them in, send mobile crisis, etc. About 123 MCT visits per month, mostly adult when it comes to MCT. And MCT, there's about 22% that are transported to the hospital, but 68% of those that go there are actually admitted. So there is, they're making decent decisions while they're in the field. So I'm going to turn it over. You good? Okay. Okay, so Officer Topping's going to offer some information when we do question and answer. We really want to welcome some dialogue and some questions once we get there.
Thank you so much. I really appreciate it. All right, and then we have one more other presentation that we're going to be working with today. It's Lemurs up in Essex County. And we're just going to pull up their PowerPoint right now, and I'm going to hand it off to them.
Good afternoon, everyone. Thank you for being here. I want to preface this by saying Essex County is a lot different than what you just heard. We're very, very rural. We're in northeastern New York. We're big square mileage-wise, but not population-wise, so we're definitely spread out a lot different, and we have a lot less resources. So I'm going to be speaking to our experiences in Essex County specifically. So any law enforcement in the room knows that often, law enforcement officers act as mental health workers in the field, and that's very certainly true in Essex County because, like I said, we're rural. It's not uncommon for our police department to get a mental health related call and have one officer deal with that for an hour or two, and try to do the best they can with the training they receive in the academy and after the academy. What we started to see problem-wise was officer frustration with these 941 admissions. It was becoming a bigger and bigger problem. We had officers actually having incident reports with the hospital because they weren't accepting 941 patients that we were bringing. They were actually refusing to admit these patients into the hospital and evaluate them. This left the officers without recourse for that person they were actually seeking help for. This actually kind of came to a peak when we had a case in my jurisdiction in Lake Placid where this individual was 941 like 6 and 7 times, and the officers really liked him. They were trying to get this guy help. They clearly felt he was suicidal, and shortly after his last 941, he ended up jumping off a building, taking his own life right on our main street. And that was like the peak of our frustration before Lemurs came along. And I'll pass along. By the way, my name is Chuck Dobson. I'm the chief of the Lake Placid Police Department. I'm going to pass along to Sarge here.
Hello, I'm Casey Colozzi. I'm a patrol sergeant with the Essex County Sheriff's Office. We have definitely taken the great strides since this program came along. But just to go on further about some of the issues we're encountering is we're having multiple encounters with the same individual in the same hospitals over and over again. They know us by first name at this point, and we have to go in Essex County. We don't even have a 941 hospital in our jurisdiction, in our county. So I'm traveling to Glens Falls, I'm traveling to Plattsburgh. On occasion, I've traveled up to Saranac Lake area. So it's definitely frustrating because, like he said, we're running with these same people, and we know them so well now that we hear the address and I know exactly where I'm going, and we want to help them. So the frustration level has grown with the admission after admission. There's people that are home before I even get back to my work area, I mean, I've met people in the same shift twice after I'm 941 them. So that was a great frustration. And the escalating patient encounters leading to criminal arrest or injury of the officer or the patient. We're going to help these people, and they can't help it sometimes. So it ends up where we are forcing our hand, and that's the last thing we want to do. I mean, we've had damaged patrol cars, we've had everything you can think of, and we have to make sure we remind all our guys, we're helping them for a reason. We're not trying to jam them up. So it's trying to eliminate that whole criminal arrest and the injury of each person, ourselves and others.
Is it my turn already? Let's work with that. Oh, I was tempted to say it, but I'm not gonna. So obviously not experienced with a microphone. I'm Jessie Morgan. I'm the coordinator for our Lemurs program. And yes, Essex County is very, very small. We're very rural. Geographically, we're, I think, the second largest county in the state. Our population for the whole county is about 38,600 people. And so we're proud of our program. And because of some of the issues that were previously mentioned, we, as a team and with many hours of planning and mapping it out, were able to create the Lemurs program, which is law enforcement mental health referral system. And so, fairly simple. When any of our officers encounter someone in the community and it's determined that there is a behavioral health condition or social determinants of health concern, regardless of whether or not they've committed a crime or charges are being filed, the officers really simply complete a HIPAA-compliant online referral form that is in real time sent to a member of the Essex County Mental Health Clinic as well as the Mental Health Association in Essex County. And once we receive it, we sort of vet it and triage based on the contents of the referral. Doug, the next slide.
Hi, my name is Doug Meyer, and I'm the Director of Crisis Services at the Mental Health Association in Essex County. We're a private, not-for-profit agency, but we work closely with law enforcement and with the Essex County Mental Health Clinic. This program was born in 2018. It really grew out of a collaboration with law enforcement on the opioid issue. But we've been doing this since 2018. It's a very simple process. It's a one-page online form. It can be accessed right in the patrol car, or a lot of officers wait till the end of their shift when they're back at headquarters. Referrals come to myself and to Jesse and a few other people. All law enforcement gets from us is a confirmation that we got the referral. We never give feedback to law enforcement on whether engagement was successful or not, unless we have a release from the person. We have a new program with Lake Placid where we're attempting to get releases on all of our referrals, and that can be difficult. All the referrals that we get receive a mailing from both agencies, my agency and the Essex County Mental Health Clinic. They have phone outreach attempts and also at least one in-person outreach attempt. Some referrals we get on people from out of state, obviously they'll just get mailing or phone call. We do triage the referrals, and people that we get multiple referrals on, we're a little more diligent in trying to get a face-to-face contact with them. So we encourage officers to, oh, I already did a referral on that guy. We encourage them not to think like that. Send in referrals repeatedly because it helps us figure out what's going on. And we track them for 60 days. Officially, actually, we track them for longer than that. But if we haven't found someone in 60 days, sometimes we'll stop the outreach attempts. It depends on the severity of the case. So forth.
Okay, so I want to preface this also by saying a few things. This was a very small change for our department that made a really big difference in the community, and for a lot of those people who were seeing over and over again. This program changed the game for us in a very positive way. Not only our officers, but community members had the option for help now, whereas before, most of the time, people in crisis would just end up at the emergency room with the police department. So this was definitely a big change for the better. And for the law enforcement supervisors in the room, I can tell you that this referral system is top proof. It's very easy to use, and that's one of the best parts about it, to be honest with you. As a result, we had less problems with our admitting hospital. A lot of those problems went away that I described earlier. We went from having to have after action meetings with the hospital based on us trying to bring these patients to the hospital to none. And that's the last 2 years. I don't think we've had a single incident where it was like adversarial between the hospital and the police department, which was great. And I can tell you the officers certainly feel empowered with this new system. They're invested in getting these people help. And like I said, especially the people they've known in the community and that continually come to us for help. It's made a big difference versus us just bringing them to the hospital against their will. We're looked in a negative light. We're actually referring them to help, and it's having really positive effects.
We're just playing hot potato with the microphone. So at this point now we have a mechanism to directly refer people from the street to mental health, which is great because we get to be able to express everything that we're thinking. Like you said, it's very cop-proof. My guys, I don't even have to ask them to do it anymore. When we run into a situation, they just know they're doing the Lemurs link. And it's so easy, it'll take less than 10 minutes, and especially when you get it down to a science, it's in and out. So it's really nice to be able to directly refer people to them and actually tell the people, hey, I know you've been waiting weeks and weeks to be able to get in to get help. This might be able to speed up the process a little bit, and somebody will be reaching out. So that's definitely been a good thing for them to be able to get services. The follow-up and the collaborativeness of the dispositions with the patient permission, they talked about that starting in Lake Placid, of them being able to communicate with us and us getting more information out there and from them. So the regular meetings aspect of it, how it works is we meet with them quarterly, which is really nice, so we can express our concerns. They can give us information. Within their department, they meet more often, usually it's monthly, but for us to be able to Zoom in or meet in person, whatever it is, we meet quarterly, and that seems to be working for us. We did meet more frequently in the beginning, and now we've kind of pushed it out. The big thing is Lemurs wouldn't be successful if it wasn't for the positive and trusting relationship between us. So I need to be able to trust that these guys are going to have our back when it comes down to us dealing with the people on the street. And they need to be able to trust us, that they're not Monday morning quarterbacking us, and we're not having to correct them of, hey, why didn't this get done? So I know when I send a referral in, I get the confirmation email that they got it, and then I can then make sure that they have all the information they need. So if they need to reach out to us, it's super easy. I communicate with them on a frequent basis whenever we have a situation, and it seems to be going really well. But it takes all the entities in Essex County to be able to buy into this program essentially to make it work, and it's worked out really well for everybody that I work with.
I just want to acknowledge Lieutenant Kim Ryan, who's the, stand up for a second, Kevin, who's the Zone 3 Patrol Lieutenant, and without buy-in from the state police, this program would have never got off the ground, so we really appreciate that. Okay, here's some data. The program was born on my birthday, July 10th, that was to be my birthday, in 2018. In 2024 data, it's a little higher now, 220 so far this year, so we're going to break our record this year. Between males and females, it's about even. Juveniles, we get a few referrals on juveniles. My agency only deals with adults, so all the juvenile referrals are handled by the Essex County Mental Health Clinic, and you can see how the referrals break down. We also get language referrals on all of the OD mapping inputs. So when someone ODs in Essex County, we eventually try to make it the next day, not always knock on their door and make sure they know where they can get treatment, give them Narcan, that kind of thing. Going out and knocking on doors at an address where the police were just there the day before. Some of these addresses are really sketchy, and we do a lot of safety training with our staff that do those outreaches so that they can stay safe also.
Just wanted to add, it's important to point out what Doug just said, follow up the day after. Before Lemurs, there was either no follow-up or it was weeks after. It wasn't 24 hours. 24 hours was a huge stride forward for mental health in the police department, for sure.
Yeah, this is a referral system. It's not a mobile crisis deal. We're moving in that direction in Essex County, but this is what we came up with as a solution to the immediate problem of people waiting weeks and months to be outreached.
Really just connecting people to resources or supports that they may need and not know how to access or not have access to.
I guess we could take some questions.
All right, thank you so much. If I could have both the partners come on up, I have a question for both sides. I just want to get us started on that. So, kind of like just going forward, I can pass the mic over to you guys if you want to, but like I think what's important, kind of like just one question that I think for us just to start for both sides. What are some key stakeholders that you guys had to get on board for your partnerships to be successful? Like what are some like key ones? So it doesn't matter who wants to start.
Okay. Hi, so I'm Officer Bridget Topping, and the key stakeholders in our collaboration were the buy-in from the police department, the buy-in from the hospital systems, and the buy-in from Family Service League. It was important to look at the reality versus the expectations of what this program, what this collaboration was going to look like, and that has evolved in the 3 years of the behavioral health section's existence. Similar to what you guys have, we have a dedicated behavioral health section. It is sergeant, my sergeant, and then myself and 2 other officers. We are the ones that sit through and look at and analyze all of the mental health calls that officers are doing out on the street. We look at that individual's history. Is it okay that I just go into this, just a little bit of, I know backing it in, but just explaining how this works for us?
Yeah, because I was just going to ask, like, give you like the details, because you know how a lot of, you start a collaboration, just saying agreeing to something is one thing, but then also like saying why that agreement works. Like, I would love to hear that.
So it's important to understand the behavioral health section works and why we're important is, and you guys touched on a couple of the items, is that we want to make sure when Family Service League goes out, our partners in this, that they're safe, that they understand who they are going to, what that situation looks like. So we refer to them through their Acumen system and a history of that individual. Are there order protections involved? Do they have a history of violence? What is the home life like? So they know who they're going out to. And also, if we feel that they need a police co-response, we will let them know that. We give as much information on that individual as possible, as many phone numbers as we have, addresses, different information, so they can be successful when they do that in-person outreach. Something that we do differently that is very successful, and I will say is important when looking into starting a collaboration like this, is we do give feedback to the officers. We close that loop, we close that gap for them, and we have found that that has made the buy-in from patrol, which is one of the most important stakeholders in this whole program, it's super important. They want to know that when they're bringing that person to CPEP or they're bringing that person to DASH, what is the outcome of that going to look like? One of the changing metrics for us was, and we have thousands of mental health calls that we sift through, is a lot of the individuals in the beginning of this program we found were already connected to services. Why were we referring the same individual to just a different entity over and over again? So we paused and we said, let's look at how we can do this in a quality versus quantity aspect. So the individuals that we refer to Family Service League now, where they can do their safe outreach, aren't already connected to services. And if they are, we can communicate with their treatment teams or their group homes and inform them of their police contact, their frequent police contact. That has been successful because we have found that quite often group homes or treatment teams, active treatment teams, may not have been aware, more often than not they weren't aware of the frequent police contact that that individual was having. We've been able to advocate for individuals that have needed a higher level of care. And so all in all, it's just been important in having this section, these dedicated officers, myself and my team, because we closed the gap of communication that wasn't there prior to this relationship existing. And officers do appreciate knowing how the call is ending, what it's looking like for this individual, because as we know, officers can get burned out from responding to the same individuals over and over again and feeling like nothing is happening, like nothing's happening. There's nothing to do to help this person. So we stay on top of that and we close that gap. We fill in that information for them. And we can communicate as police officers that have a passion for being part of the solution to this crisis in police language to our officers. So it's important to note also that myself and my team, we do not have a background in social work. We're passionate about what it is that we do. We've been police officers for a very long time, but we have to close that communication gap and communicate to police officers what's happening with that individual from the social workers. And it's just a really important piece of this, so.
I'd just echo what you said. I mean, I think if you were to start this program from scratch, investment from the police executives is paramount importance. I mean, if they don't buy into it, the officers won't buy into it. And it's really important that they be involved right from the beginning at the ground level. I think it's really important.
One of the really important parts, and I know Dr. Steigman touched on it, was at the ground level when recruits are in the academy, we send them to DASH. They get out on the street as patrol cops, knowing what is the change, like it's not a change for them. They are used to being around social workers and having social workers that are going to respond to calls with them. We also, the behavioral health section with our partners at DASH, we speak at every training in the Suffolk County Police Department, every SRO school, every FTO school, every supervisor school, every mental health training, crisis intervention training. So everybody in patrol is seeing us, they're knowing us, they know they can come to us, and they're getting the same information as opposed to different pieces of information from all of the different entities around the county. So it's important to have that, and just cops do something once, and if it doesn't work, they don't want to do it again. We have to show them that this isn't going away, that this relationship that we have established works, and they're getting out there and we're seeing it, and we're seeing in the numbers that they are taking people to DASH when they need to go, when they get somebody that volunteers to go. They're reaching out to us when they know that there's somebody that needs assistance and they feel like their hands are tied, they don't know what more there is that they could possibly do. And like I said, it really is just closing that gap that's really important.
Thank you so much, I really appreciate that. I'm going to open up we have a few minutes left. Just want to open up if anyone have any questions.
I had a question for the Essex County folks. So my sergeant and I work from the state police. We're kind of unique as where we are. We bought up in Oneida County. On top of that, we have trained from casinos. We have a lot of people that come from outside of our jurisdiction. We've run into that issue with our mental health problems, and
try to start with that one. So Lake Placid, if you're not familiar with it, is a tourist destination, constant events, constantly people from out of town and even internationally, right? So we run into mental health calls involving those folks. Our policy right now is to make the referral. Make the referral with their local information. They might be staying for a day, they might be staying for a month. And then see if the health department can follow up with them.
And so just to add to that, our program is being picked up by a lot of our neighboring counties and kind of starting to slowly spread across the state. So we're becoming more aware of county-to-county connections, right? So, and also our county kind of has all of these bordering counties. Some of the towns are split between two counties, so we are always getting referrals, and we're like, oh crap, but we are making the connections now, and we're able to kind of forward it on or have a contact with another county kind of leader or person who can then start the connection process. Yes, and we can, and especially under any kind of crisis umbrella, for the most part, we can share more information under the LGU's umbrella.
I know you said it was for them, but on Long Island, we actually do have a decent tourist population, and along with people that are experiencing a mental health crisis, we also refer every person that has had a Narcan-administered opioid overdose to Family Service League. Very difficult population as far as getting correct pedigree information where they can go out. We still do the referral. We take whatever information we can get from that individual, whatever patrol has given, and we will, if we see that that person is in a real crisis, reach out to other police departments. So the Suffolk County Police Department's like in the middle of the county. We have Nassau, then we have a lot of villages around us. We can communicate and see if something is going on with that individual, maybe not through our jurisdiction, but surrounding jurisdictions, and we can still refer them to Family Service League. And if necessary, they can then outreach another nonprofit or agency to connect that person to services.
So this sounds as heavy on worse substance use. The question that I have is if someone doesn't fall into the criteria of substance use or severe mental health disorder, there would be some mental and emotional health distress. Is that the limitation of your referrals? It's not that something like substance related?
Absolutely not. We get all the time referrals from boots on the ground patrol. An individual may never have a mental health call for service. They may have never had a drug overdose. They may just be in crisis, and we don't know what that is. It was one of the parts of this that was, I'm stealing your line. We were building the plane while flying it, and having to look at and change some data and the metrics that we were looking at. Like I said, when this started, our metric for a mental health call, those individuals were already connected to services. They're getting their treatment. We need to look at the individual that just has 17 disturbance calls. What's going on with that person? The old lady that keeps calling at night for lift assists out of her bed. What's happening with that? We haven't pigeonholed ourselves into any one category at this point. Quantity over quality. We're looking at the individual and want to see on a whole what's going on with them and connect them to services if need be. So we're not in those two categories of substance use or mental health. And I think it's one of the great things that we started doing when we looked at juveniles. Let's get in when that 11-year-old is having their first suicide attempt and see what's going on. So it's more than that. It's not just that.
Yeah, but also believe that not just one become a resource. We are a resource that we make contributions to something that one of the folks involved have to
What do you mean?
like we run an organization that focuses on mental health, emotional well-being. So it's like
Where are you located?
In the Bronx, Brooklyn, Harlem,
Okay.
around there, and this spreads out through the boroughs.
Yeah, we could talk after for sure, but, you know, it's, you know, I wanted to, I'm gonna come back to you in a sec, but one thing I wanted to mention, because it goes back to the question of, you know, visitors or people out of town. We had a case recently which just exemplifies, you know, the partnership and the collaboration, where there was a mother from out of state who was, you know, very psychotic actually, who absconded with her child, and drove across many states and came to Long Island, and we were able to work with SCPD, with, you know, the family, the father in this case, who had to fly from out of state to come to kind of retrieve the child in a safe manner. And we were able to work together to make sure that this child was taken care of, that the father was able to get to us safely, while also getting the care for the mother, who was, you know, really quite psychotic, and she had to go to the hospital. So that's just one example of many that, you know, we're able to really be flexible, work together, collaborate, and really for the you know, optimal outcomes. But going back to your question, so when you say how do you, I mean, the program that we're talking about it covers all of Suffolk County. So it doesn't at this point expand, but what I will say is that the DASH program was really a proof of concept, because this was, we didn't, you know, in New York State, we were behind the times in many ways compared to other states where they had crisis stabilization units, they had this level of care. So we were a little bit late when it comes to this type of program, but based on this proof of concept, I can say, and some of the stakeholders and the partners were the Office of Mental Health, Office of Addiction Supports and Services, OASIS for New York State, our local government unit, obviously the police department. So with what we built and kind of showed the value of it and how we were able to address some of the pain points, we worked with the state agencies to basically say, all right, this does need to be replicated, going back to the earlier slide. So now you're going to see crisis stabilization centers, intensive, which we are, and that just allows us to, we have nurse practitioners as part of the multidisciplinary team, social workers, CASACs, peers, and mental health assistants. So it's going to be, so now throughout the state, throughout New York State, you're going to see similar stabilization centers crop up, because we know that it works. We know it's a true diversionary model. It's making sure that people don't unnecessarily keep going to the hospital. So, you know, I would say within the next several years, there are going to be, throughout New York State, these models, you know, coming to fruition. And you know, what I always say, and what Bridget and I always say is, this should be the norm, not the exception. And we keep trying to push that envelope to say this really, you know, shouldn't be an exceptional situation. So,
one thing I did want to mention, when we receive referrals from law enforcement, on the referral form, there's a question, did the subject agree to the referral? So if they did not agree, we never reveal law enforcement as a source of referral. We always just say a concerned community member. And that helps quite a bit with feedback, negative feedback to law enforcement.
and anything I would just say in terms of, well, they can stay up to 24 hours or 23 hours and 59 minutes. So there are plenty of people that will come in, you know, if someone needs to sober up, they don't need to go to the hospital. It's not a medical issue where they're going to be, you know, medically at risk. They can stay. They can stay if they're waiting for a bed at a, you know, medical detox or substance use rehab. If we have to wait, you know, to get a bed, you know, for the next morning. So the average length of stay at DASH is about 3 hours. But there are people that stay overnight. There are people that come in and within an hour. We are able to initiate Suboxone for someone who does have an opioid use disorder. We're able to bridge scripts. So if someone was initiated on Suboxone, they couldn't get a follow-up appointment in time, we will bridge those scripts until they're connected. So that, you know, again, there's a lot of things that we do working with our partners.
All right, I think it's going to be it. I kept you guys a little longer, but I appreciate you guys staying. Thank you so much. This is for Essex and New County, and New and Essex County, and DASH in Suffolk County. Thank you so much. We really appreciate it.